Hello, everyone. Welcome to our True Let's Chat. This is not your mother's menopause. Happy World Menopause Month. We're so excited to talk about how menopause doesn't have to be a dirty word. It doesn't have to be something you suffer in silence. And so we're excited to talk tonight about our unique approach to menopause at True. It's a team-based approach. And so on that note, I'd like to introduce my two partners, Susanne Pettigrew, who is a PA, and a certified menopause practitioner, and Dr. Celia Egan, who is also a certified menopause practitioner as an internal medicine doc and board certified in obesity medicine. Hello, you guys. Happy World Menopause Month.
Happy World Menopause Month.
Thank you. It's great to be here.
So what I thought we'd do first is each talk about our own areas of expertise and why we care about menopause, and then talk about our team approach here at True and what women can expect if they were to see us. How does that work?
Sounds great.
Good. So as you guys know, I'm an OBGYN, and I have delivered babies and done surgery for over 25 years. And I became really interested in menopause when I went to my first women's health conference. And they talked about menopause not only as a time of hot flashes and night sweats and all of the other symptoms that we could talk about, but also it's the biggest risk factor for heart disease, for stroke, for diabetes, for obesity. And I wanted to become an OBGYN who also knew more about the heart. And so that's what got me into menopause, and I couldn't unknow it. I can't not do this to help women, have the menopause they want. Susanne, what is your background? What brings you to menopause?
Yeah, thanks for asking. I have a family practice background. I was in primary care for about 30 years prior to getting into other areas of medicine. Subsequent to that, I got a holistic health certificate in primary care. I dealt with just really a wide range of health issues and started noticing the problems that women started complaining about in terms of menopause changes, hormonal issues, mood issues, sexuality concerns, things like that, and really realized that I did not have the level of knowledge that I wanted to have. My career path shifted a little bit and took me from family practice into cancer survivorship, which taught me a lot in terms of assisting cancer survivors and transitioning beyond their therapy and into wellness beyond cancer therapy. From there, that actually began the beginning of my relationship with Dr. Bitner. Her and I met each other in the cancer, menopause, sexual health clinic that we worked in together, and that's kind of the time frame that I really developed an expertise in dealing with cancer survivors and really had an interest in learning more about menopause and sexual health, and really is the beginning of something wonderful as it is today.
I remember when we worked together at our clinic called Cancer, Menopause, and Sex, and you came out of a room with a patient and you had really helped her find her new normal.
Yeah.
And you were like, this is it. I love taking care of these women and doing this. Like, I'm so excited. So
yeah, I was thinking about that last night as I was preparing that was a good thing to mention. I remember coming out and saying, literally, I was born to do this. And I knew
you did say that.
I found a niche that I could really contribute
right.
with.
And it's just so exciting how you joined True. We've been open, 2.5 years now,
Yes.
something like that. And it's gone so fast. And it's just awesome. Celia, I just remember the day that you called me and we first met, and it was just such a good fit. I'd love you to share about your background and what brought you to menopause.
Well, I'm a doctor of internal medicine, which means the medicine of adults. And I actually started my career kind of at a major cancer center and dealing with the opposite end of the spectrum of, more end of life, kind of more life-ending illnesses. And honestly, that wasn't for me. And so I took a step in the other direction and I started doing more preventative care. And through that, I got board certified in obesity medicine. So I was doing a lot of primary care and, helping patients lose weight. And I did notice that there was this chunk of women that it was a little bit more of a struggle. And some of the medicines don't work. Some of the basic recommendations don't work of the, eat less, move more. And, I really started listening to patients, and a lot of them talked about their struggles with hormones and where they were at in their phase of ovarian function, which is how I sought out Dr. Bitner to say, hey, everyone says you're good at hormones. What the hey is going on here with this menopause situation? And that's sort of how I got into menopause, was at listening and then asking some questions.
It's so exciting. I remember years ago, really thinking, I had this image of like the woman's in the middle, and like I think we should be around her like the spokes of a wheel. We should be, her team, and she's in the middle of our care. And I really, early on wanted to have a network of providers that each provided a unique aspect of her care. Like I can be an OBGYN who knows about the heart. Susanne, you taught me so much about cancer and cancer survivorship, but I also wanted to work with providers like you, Celia, that you're an internal medicine doc, but you get hormones. So I love how all of us together can take care of our patients.
Yeah. And I think even just pausing for a second to even just listen to women and acknowledging where they're at with their phase of ovarian function, with their symptoms and just what's happening, I think is sometimes really underrated from, other primary care offices where it's just, not enough time, not really the same thought thread. So I find that's really unique with our practice.
Exactly. Yeah, and I think we've learned that it literally takes a village to assist, in moving with women forward through this stage. It's not just, menopause isn't just a medical problem. It's not just a diagnosis. There's so many contributing factors to it. The hormone changes are a piece of it, but everyone's journey is so individual as they go through it in terms of what's going on in their life. What are their relationships like? What are the stressors that contribute to it? What are their lifestyle habits? What's the nutrition status looking like? And so when you put a group of people that all have, different expertise, it really is optimal. So that's one of the reasons why it's so exciting to be working together.
Well, and two, every woman experiences menopause differently. And, just to say to the community, I am a white woman. I'm not a woman of color, but I'm curious about how each person experiences menopause. Women who are, who just have a different experience than me. It's like what I love about our attitude here at True is we're very curious. We want to know about people's experience, no matter their background, no matter their race, no matter their socioeconomic status. Like we're about women feeling better and reaching their health goals. And I know you guys share that. Mm-hmm. Here we are in West Michigan, but we have such a unique, diverse community. And we know that, for example, women of color tend to experience hot flashes longer than white women. They tend to be more intense. And we also know that early hot flashes tend to increase the risk of, or tell us that she has an increased risk of heart disease. Celia, what were you most surprised about when you learned more about hormones and the whole?
I think some of the options for treatment, because I will say that being in internal medicine, still even to this day, I think that the treatment plans are not really nailed down nor discussed. It's kind of like, okay, I always thought of, when I think about menopause, I think of a time when diseases started. That's kind of how I viewed menopause. And it's just sort of like, all right, well, there's going to be all these problems, kind of just wait. But yet in hindsight, like we never really had a very clear, concrete plan as to what to do with the symptoms and prevention of some of the disease processes. That was taught in a clear way, such as diabetes or cardiovascular disease or cancer, for instance. I feel like I had, eons and eons of lectures about those things. But menopause in particular, I don't think that there's enough medical education surrounding in terms of treatment plans, not only medical treatment plans, but also lifestyle treatment plans that are really helpful in changing some of the symptom pathways.
No, exactly. Here in Grand Rapids, I was a part of the study that was published. We surveyed all the residents in Grand Rapids, internal medicine, family practice, OBGYN, and found that only 6.5% of residents graduating from residencies were comfortable taking care of women in menopause and treating their symptoms. 6.5%.
That's not enough for 50%
not enough.
of the population.
Women deserve. Yeah. Susanne,
sure.
What was your experience in family practice in terms of care plans for menopause?
Yeah, it was sort of interesting. If I was the only woman at, the health center that I was at, usually I was the one that everyone would come to because women, I think, were just searching for answers and just not getting it. And they figured if they at least talked to a woman who maybe, had a little bit more depth of understanding into it that would be better. But, I learned that I didn't have the knowledge that I needed. It was back in the day before all the data around, the pros and cons of estrogen came out, and it was a time where I was prescribing a lot of estrogen, and then the literature changed. And so I really appreciate the fact that we keep, up on the data. We know the pros and cons of estrogen. We know who to use it in, who can use it safely, who should use it safely, who shouldn't use it safely. I think the other really big valuable thing was the being able to talk comfortably about the topic of sexuality. I still remember very clearly in primary care, patients would always save that topic until the last, and we're like out the door.
And say, oh, by the way.
Yeah. But you also didn't have all the answers. And so, I always felt like I was discounting them. And I'm just so grateful now that I do have answers and I'm comfortable talking about it. And it's actually a topic that I bring up so that I can actually engage with patients about, because it's such an important issue. And women deserve to be able to talk to someone in a comfortable and professional way and get good information.
No, I love it. And I think women really want to know why they're experiencing their symptoms. Maybe it is that they're carrying extra weight, or their blood sugars are out of whack, and again, here at True, I just love that we have our whole team. Wednesdays are one of my favorite days here because we have our team meeting every Wednesday morning, and we talk about patients who might need, more conversation between all of our practitioners. And here at True, we have the three of us. We have our three amazing nurses. We have 2 therapists because, of course, mental health is a big component of aging and menopause. And then we have Kara, who's our pelvic floor physical therapist from iMove, who is here. So I just love our team-based approach. Celia, I would love you to talk a bit more about our complete program in the sense of how we use wellness, or how we break wellness down into the different components.
I think the words that we've used, which I think are a good way to describe it, is it's primary care plus, right? So it's doing all the things that a standard primary care office would do, but only we emphasize a lot more about prevention. And not only do we want to talk about prevention as in, making sure that you've gotten your cancer screening and checking the boxes, but we want to come up with a plan that makes sense for every patient. And we have a kind of a process and a system that we review with patients, and then kind of a game plan. And not just, the basic labs. We spend a lot of time thinking about, what are the new advances in any diagnostic testing that's available. We care a lot about, maybe things that are cutting edge. And we spend a lot of time reviewing the literature and understanding if that would be a good test for our patients, at least to offer, just so that it's available for our patients to do. In addition, we love, as we've already mentioned, we love talking about nutrition and sex and exercise. And probably if you ask a question about any of those things, you'll probably hear more than you ever wanted to hear in your life. So, I think that those are the questions that patients, really the topics that patients have questions about, right? And we're happy to sit down and really go into the nitty gritty about, sex and food and communication between maybe you or your kids, and kind of trying to understand those different things. So that's what we think of as primary care plus, all the aspects of primary care that, obviously all women deserve, but then all this extra stuff that all women really need. And I think that one of the things that we pride ourselves on is really trying to be as available as possible to talk with patients. So we have a great communication system, and we really try to keep our space open for patients to be seen kind of right away. We don't want patients to stew on medical problems. We really want them to be seen. And whether that's a video visit or a telephone call or coming in, we really want patients to feel like they have access to whoever they need to, when available.
Yeah, I think I get a lot of questions from patients about, well, why do I need primary care? Why is primary care even important? And I think there's a couple of concepts that I think that are really important to kind of own. And primary care has a large focus on prevention, and certainly in our practice, we are always thinking about not only treating the acute problems, but always thinking about, how can we get ahead of something? How can we How can we get ahead of diabetes and treat pre-diabetes? How can we treat even the step before pre-diabetes? And the other piece of primary care is just that it's a comprehensive way to approach a patient. We don't just see people just for menopause. It gives us the opportunity to see patients for a wide range of problems that include acute problems, chronic problems, prevention. When you see the same team of medical providers, it really enhances your ability to get comfortable with communicating with them. It gives the model that we have allows easy access to getting appointments, and we're accessible. You can usually text us and you'll get us directly. And we also are really good at just helping to coordinate care. We try to do as much as we can for you, but we also have the capability of referring you to a specialist and then trying to really coordinate that care beyond that referral as well.
No, that's awesome. I'm glad you brought that up.
I want to have one point. I think this can't be said enough too. There's something about having your doctor know you.
Yeah.
Right. To know what's important to you, to know what's going on with your life. Right. If you're, let's just say, for instance, you're a busy lady and you're traveling for work all the time. We need to know that. Right. We need to think about that. Let's come up with a plan for eating in the airport. Maybe you get frequent UTIs. We'll have you some antibiotics just to go because you know that we can't get back and forth. There's something about having that relationship that's sort of at the essence of what I definitely primary care and medicine's all about. And some of that's been lost, I think, with the lack of primary care providers. People kind of even forgot what that was. But I think we all kind of hold that dearly of how we really we love getting to know our patients, and not just the labs and things, but really, their lives and kind of what makes them them.
Well, I love when I walk down the hall, I hear people laughing behind the doors. Our therapists are laughing with their patients. We're having a good time with our patients. We really love what we do. And so I wanted to say, first of all, for all those of you out there listening, please feel free to ask us any questions. I appreciate Christina's comment about, yes, only 6%. But please feel free to ask us any questions. We all could just talk for hours. And so, again, please ask us any questions. One thing that I love about what we all share in common with our mission is that we really, like you said, want to get to know our patients, and it's about their goal. So one of the things that we ask is, what is your picture of self, or how do you picture yourself? What's your goal at a future event? We're not our patient's boss. We don't tell them what to do. We just really want to understand what they want and how we can help them define their wellness, not how we see it, but how they see it. I see you two nodding. Like I think this approach has been helpful. What do you guys think?
Yeah, I think it helps me to really focus on, what are the nuances of the person that I have sitting in front of me. Like, what does she want? It's not about me making sure that her hypertension is well controlled and her lipids look good on her labs, but it's more like, what's important for her? What's going on in her life that she wants to be a certain way for? And my job is to focus on that. And, I'll throw in a few prevention things and planting seeds for wellness going forward, but my focus is going to be on what's important to her.
That's awesome. And Celia, I hear you saying you're a board certified obesity medicine doctor who cares the least about weight of any other obesity doc.
Yeah. Yeah. I mean, I was just even thinking, when we're thinking about where patients' goals are, I mean, the amount of dietary recommendations that are out there are, north, south, and every way west, right, to California. So it's really, unless a patient has a goal, right, we could make a lot of different food recommendations and nutritional plans. And that's why it's really important to listen to patients about what they want to do, what their goals are. And we're really here to help kind of narrow down some of these things and make all that noise about weight loss seem a little bit easier to kind of handle.
Right. I remember hearing you talk about your conversation with a patient recently, and you were saying, it sounds like all you've thought about for the last couple of years is every detail about your food. I think you recommended, let's just stop thinking so much about food. Just make one decision, one change. And it really flipped a switch for her. It really helped her see everything differently.
Yeah. I mean, sometimes even just stop doing things, right, can be helpful. And a lot of it just depends on what patients' goals are.
Yeah, exactly. So Kelly, we'll get to you, but first Maria is asking, how soon should we be starting to track hormone levels, before menopause, during, or after? I guess I'll take this one quick, and then Celia, yours is the next. But basically, Maria, it's like it's not more about levels, it's about your story. So we know that perimenopause happens usually in the mid to early 40s, and it's a time when the periods start to change. And menopause means 12 months of no period. The time, well, no, back up. So we mostly can figure out where your hormone levels are from your story. You know, what time of the month do you have more breast pain? Which time of the month do you have more mood change? When does your period come? Where hormone levels become more important if you've had, let's say, an IUD in your uterus and you don't have bleeding, or you've had surgery and your uterus has been removed, or you've had an ablation. So, you know, we check hormone levels when it's going to change what we do. Just checking hormone levels doesn't necessarily help us a lot, especially the salivary levels are not something that we recommend. So we really want to get to know you and your symptoms, and then we put it all together. So I hope that answers your question. Celia, do you want to address Kelly's question?
Yeah, so Kelly Girl says, I'm worried that I'll never get my weight back under control, especially this visceral fat that came on so quickly. I'm very active lifestyle, and that took a dive with no amount of exercise helped. I feel like we hear this question a lot, and unfortunately can feel so overwhelming and frustrating when you're trying so hard with a ton of exercise, and yet you're not seeing any changes in your visceral fat. You know, there are some changes we can make nutritionally and with some other medications that can help kind of get our body sort of back in line in terms of wanting to get that fat level back under control. It's really interesting. You know, our bodies are trying to do us a favor when we start storing visceral fat. And a lot of the times it's a misfire of the sugar processing that's happening as our hormones change, right? So insulin and estrogen, which is the hormone that our ovaries secrete, right, kind of run hand in hand. And as our ovaries stop secreting estrogen, that connection sort of changes. And a lot of times we can see an increase of visceral belly fat. Exercise is a broad term, and I know we all sort of make some recommendations about changing up exercise. And sometimes it's even pulling back on certain things and adding other types of movements that can be helpful. So we have a lot of different ideas of how we help that belly fat number, and it depends on the patient and sort of what we see in the labs.
But I would say that we've got really great success. I just love it as patients are, you know, getting a plan that's specific for them, their phase of ovarian function, their history. Like if they had diabetes in pregnancy, they're much more likely to get the visceral fat. So it's really fun here to put it all together and work together as a team. I just love that.
Yep.
Suzanne, you want to talk to Christina?
The other thing I'd add to that is just, you know, with my training in functional medicine, you know, some of the things that I didn't used to, you know, talk about as much, but just, you know, looking at the role of inflammation in contributing to belly fat, and also the role of stress and how, you know, the normal everyday stressors, you know, that we're under, and how that contributes to our bodies spending a lot of time in fight or flight, and how that contributes to cortisol levels going up, and the importance of having some type of a relaxation practice that allows us to mitigate that. And, you know, in addition, and that I say that in addition to everything that Dr. Egan just says, it's not a standalone, but often it can augment that process as well.
Again, it's about our team-based process, right?
Suzanne, do you see a lot of women that are stressed? I'm joking. It's
like
stressful.
Everyone. I mean, when you think about what we have been through just as a nation and a universe, you know, in the last 2 years, like who isn't under stress? If you think you're relaxed, you still have a baseline of stress.
Exactly. And we just want that, you know, we're all living this crazy world, but how can our insides not suffer the consequences, right? How can we not give that stress power? So Suzanne, I love even how you teach people meditative breathing, and we talk about the power of gratitude. So it's really looking at that. And of course, our therapists with cognitive behavioral therapy and all the other tools that help us cope. So super important. Christina, I see you're saying that you're 49 and you're 15 months post-menopause. I'm so sorry that you're struggling. You don't have to. It's World Menopause Month, and we can bring awareness. Hot flashes and night sweats can really add to your stress, right, Suzanne? Like when people aren't sleeping. I'm glad that you're limiting your sugar and your caffeine. Again, Suzanne, do you want to talk a bit more about this?
Yeah, I mean, so she's 15 months post-menopause. I'm assuming that means that her last period was about 15 months ago. So it's a really, you know, so she meets the definition of menopause. And so her ovaries are no longer making estrogen and progesterone. The night sweats, are about, the body's comfort zone kind of getting reset. And so she used to have a wider comfort zone. So her air conditioner would go on when she felt hot, and the heater would go on when she felt cold. And so estrogen levels go down, and that thermostat is like malfunctioning. And so the night sweats and hot flashes are the body's, smart way to try to compensate for that by causing, flushing and more blood flow to the skin to aid in that cooling process. And so things like, making sure that you're drinking plenty of water are helpful, doing relaxation techniques, eating a diet that's, as you say, limiting your sugar and your caffeine. Definitely there are medications that can, be used in addition to lifestyle strategies to help with those menopausal changes. And estrogen replacement is certainly something to talk to your menopause practitioner. Hopefully you have one about, to see if it's a good fit for you.
Or Christine, of course, if you want to come see us, if you're in the area, we'd love to see you.
Right.
It's just, what's so fun is there's so many options that we have to help you feel better. And again, we know that 80% of women go through what you're going through, and we like to really help you. So again, you can feel better, but also reach your health goals. Michelle, I see you've got a question as well. I had a hysterectomy at 30 and now have Hashimoto's and hypothyroidism. I feel like I'm out of whack from head to toe. Yeah, these are tough issues, but the great thing is that there's lots of information, and Susanne has had extra training in thyroid disease. And I remember when you finished that set of lectures with Aviva Ram and her functional medicine training, you were like, I get thyroid. So,
yeah,
it's a big deal.
And hypothyroidism is more common in women with menopause as well. But, so Hashimoto's is an inflammatory problem in the thyroid gland, and it usually results in your thyroid becoming hypoactive. And so, aside, in addition to medical therapy for that, there are lots of, nutrition related kinds of things and reducing inflammation that we can talk about that I need to, kind of individualize depending on your specific case, of course, but lots to talk about there.
Yeah, and I'd love to be able to answer women's question about that. And I appreciate the pop-up on the website. You can actually go to our website and take a quiz and rate your symptoms. There's 7 main menopause symptoms. And actually, we published the scale in the journal Menopause this summer. It's now a validated scale for menopause. The 7 questions, 3 is good, 1 is difficult. And so you're able to track your symptoms. And then when you add a lifestyle habit, when you add let's say a therapeutic like a hormone replacement therapy, you're actually able to track and see if that changes. And so, that's a really good option. What I want to also bring up is our waypoint structure. I think we have a informatic here to show what is waypoints. And if you go on the website, you can see more about our complete wellness plan. But this is where we go through the 9 areas of wellness with each woman. And again, sometimes how you go to a doctor's appointment, you leave and you're like, what even happened? It was great. But so when you're a patient of True, you actually get a binder that we have all these different areas of wellness laid out. And we ask about your goal in each. And then we use stratification. We use risk scoring in each one of these areas. And so we're able to come up with a life plan for you based on your goal in each area. Some people want to be really active and run a triathlon. Some people are okay putzing in their garden and just being active and traveling and shopping. And so everyone's different. So this is a way that we can look at each one of these areas of wellness that impact your overall aging. And then we look at where you are in this, and then we help you develop a plan. So again, I just wanted to call this out, is that we really have structure around wellness. Celia, I would love you to talk a bit about heart disease risk, because again, there was a lot of talk at the Menopause Society meeting last week in Atlanta about how hot flashes really are an indicator that women have maybe a higher risk of heart disease. And so I really want women to understand what's involved in understanding their risk.
Yeah. So I think one thing to sort of note, which is really interesting. So what we're talking about is having vascular disease or blockages in the major plumbing that supply our heart tissue or our brain. And having a blockage is having a heart attack or a stroke. So obviously we do a lot to try to keep all that plumbing open. And very interestingly, women before menopause really have low rates of having heart attacks and strokes, unless they have some other sort of medical condition. But for the most part, compared to men, they're much, much lower. But then, as women go through menopause, those rates really go up kind of shockingly. And so there's clearly something that happens in this menopause time that either increases our risk factors or the actual disease process of vascular disease itself. And, we can look at a variety of different things, including, metabolic disease. So weights, blood sugars, high blood pressure, our different cholesterol levels, all the different levels, whether they're going in the right direction or the wrong direction, we can see happen. And we can see sort of changes with our heart function and other sort of different markers of having cardiovascular disease. And so it's really important, in this 5 to 10 years surrounding menopause, of really tracking all these risk factors very carefully, because there's a lot of medications that we can use and lifestyle changes to kind of get a handle on them before, maybe we reach this tipping point of developing vascular disease. So it's really important to know kind of where you are in terms of your phase of ovarian function. And if you're having any changes of your menstrual cycle or any symptoms of maybe perimenopause, to really start paying very close attention, because as I know, all women are so busy taking care of so many other people, right? But really sort of taking some time to think about yourself and looking at where all those risk factors are, because we know on average that they trend in the wrong direction, meaning they all head in the wrong place that would increase our risk of developing vascular disease. And one more side note, particularly if you've had any issues during pregnancy. So if you've had eclampsia, high blood pressure during pregnancy, gestational diabetes, those can all mean that you're at higher risk of developing some of those issues or higher risk factors for vascular disease down the line.
Exactly, including women who have had babies with growth restriction. We worry about, right, blood vessel.
Yes.
So yeah, just a really big deal. And what I love is there's so much more information, for example, about the use of hormones in women. We certainly don't prescribe it to reduce the risk of heart disease, but we know from some studies that it definitely can slow progression. And we know that women, for example, who have menopause before 45 have a risk of having their heart disease develop a lot sooner, and the risk of heart attack if they choose not to take hormones or they're not given that as an option. Now, if women already have heart disease, hormones could maybe increase the risk of an event. So we want to really be careful. And all three of us, you notice the letters behind our names, the NCMP. That means we're a North American Menopause Society Certified Menopause Practitioner. And so again, just like Susanne said, we keep up on the data, we keep up on the latest and greatest, and we know who it's safe for to take hormones and who it's not. What I'd also like, Susanne, one of the areas of waypoints is cancer. And we know that women don't want cancer, of course. And so could you describe a little bit how we think about assessing a woman's risk for cancer and how we address that?
Yeah, I would just add that, just using these 9 components of healthcare, I think is just such a useful framework to really help us do our best job in taking care of women. Because sometimes you get really focused on just addressing the little things that come up, at each visit. And then at the end of a year, there's all these major things that never got covered. And so, the 9 components of care that we try to make sure that we cover in our complete wellness program really make sure that we're accountable to that. And so, so the cancer category C, it stands for cancer. And so I will sit down with a woman and go through the 3 top cancers are most common for women are colorectal cancer, breast cancer, and lung cancer. And so, and then I include other relevant cancers to that particular person. But so we sit down and go over a woman's personal risk, for those cancers. Does she have a family history? Does she have other things that might put her at higher risk for that? And go through what are the screening recommendations that we would have for her in her particular situation, go through those recommendations, and then go through if she's at high or moderate or low risk, go over what are the prevention strategies, the things that she can do for herself that might be able to help her to lower her cancer risk.
No, I love that because, it just kills me when a woman gets breast cancer, for example. But if we had only, looked at her risk factors, perhaps it could have been found earlier, or it could have been maybe prevented. So I just think it's so critical. We like to not have to think about this stuff, but some women do have a higher risk. And if we discover that, there are things we can do, right, with advanced screening and perhaps a breast MRI or an ultrasound with a mammogram, or, so I love how you think about that. There also was an incredible lecture at the Menopause Society meeting about the power of nutrition and how, I think I could have the number wrong, but 30% of cancers could be prevented with nutrition, and then of course early screening. So, I think this is so important to touch on. Very briefly, Kelly girl, just to answer your question, you say, how do we know when we've reached the other side and no longer need hormone replacement therapy? First of all, we know that it's safe to take hormones even after the age of 65. If you're healthy and you've done well on them, there's no reason to stop. So, one perspective could be, how do we know we don't need HRT? For some women, they really feel good on HRT for a long time, and it does reduce the risk of osteoporosis. It reduces the risk of getting pain with sex or painful intercourse. It helps maintain libido and energy. And so again, it's FDA approved to reduce risk of osteoporosis, to treat hot flashes and treat vaginal dryness, but we use it off label also for other conditions that we know it's effective for. So again, it's a personal choice. Hormones should be a personal conversation that you could have with any of the three of us about if HRT is right for you, when to start it, when to perhaps stop it. Anything else you guys want to add to that?
I think a lot of people think of like just getting on the other side. I think that's a great way of phrasing it, but I don't think there is another side, right? Because, our bones still need estrogen, our muscles still need estrogen, our brain still needs estrogen, our liver still needs estrogen. And those are a lot of the really important organs that will not be getting it if we don't do hormone replacement therapy.
It's a little bit like moving into adulthood. Like once you're an adult, you are an adult. And it's like menopause is a little bit like that too. Once you're menopausal, you are in that phase of life.
Right.
And so, but it's a common question, when is menopause over? Yeah.
So
I think when I sort of think about for my patients, I'm thinking a lot about protecting their bones and protecting their muscle mass, which I don't think can be understated, how valuable those two things are. If you are not someone who gets cancer and not someone who gets vascular disease, then your big thing is having a fall, right? That's one of the major life-ending moments of someone in their 70s and 80s. And so we really hope that we're going to try to do everything we can to keep our bones strong and keep our muscles strong, to protect our joints and protect those bones so we can keep doing all the great things that we want to do in life. And that's one of the main reasons why I would hope that patients would want to get a little bit of that estrogen signal to continue with
exactly.
And I think it's an ongoing process of having this continuous conversation with a practitioner who hopefully specializes in menopause and keeps up on the knowledge in terms of, repeatedly looking at what are the pros and cons, what are the risks versus benefit for me at this phase in my life. And that has to just be re-talked about every several years to make sure that, there's more benefit than risk for her to stay on it.
I love that. And what I was just thinking about too, Celia, when you mentioned the bones, we think about how everything is connected. So for example, if a woman develops vaginal dryness, we call it genital urinary syndrome of menopause, but she gets vaginal dryness, bladder urgency, and then maybe she's rushing to the bathroom because she doesn't want to have an accident, and then she trips on a rug and breaks her hip. So if we can help control her bladder urgency, then we may actually help prevent a fall. And then if her bones are strong, she's actually preventing a fracture. So, guys out there, it's just all about, and then the muscle mass helps her, not fall in the first place. So it's about this total wellness that we really want to bring to every woman that we can. We want to reach as many women as we can. So, please tell your friends about True Women's Health. We have our complete package, and we just love to provide this total care to our patients. As we close out tonight, you guys, any parting words, anything you'd like to leave people thinking about?
Sometimes it can feel a bit overwhelming just to go on to a complete package, but we do have some other, if patients are, hey, you know what, I just want to talk about weight, or I just want to talk about menopause. There are some other things that, other packages that people can, still learn about their bodies and learn some plans that I think are really helpful as well.
No, I love that. And the cancer wellness program that Susanne takes care of, it's the same sort of thing, but you're getting a provider in each one of these areas that knows about the other areas. So we can bring them into play as needed. I also love our Empower program, taking care of women 25 and under who need to talk about family planning or sexual health or what vitamins to take or, how to cope with going off to college and adulting for the first time. So, right, Suzanne, like I know you and I see most of those gals who do our Empower visit. So it's just so much fun.
Yeah, we all agree that the complete wellness program is our most comprehensive program, and we're really able to provide the whole package for women, and all three of us work closely together. But we also have other options because there's a variety of reasons why maybe that's not a perfect fit for every single woman's. And so the basic wellness is a nice way for women to kind of just get in and experience us and focus mostly on like the women's health GYN aspect of the care. And many patients who enter into that program actually upgrade into the complete wellness because they want us to do all of their healthcare for them, and empowers the same way that a younger woman can try us out. And our silver wellness is similar for women over 65. So we really have so much to offer in trying to match all of the needs and preferences for all of our patients.
Exactly. And, I've taken care of many women in West Michigan for over 25 years. And, I am not a primary care physician. Many people, back in the day, OBs could be your primary care. Now we can't be your primary care for your insurance, but thankfully Susanne and Dr. Egan can both be your primary care if you were to be in our complete wellness program. So again, we just love what we do. And also a quick shout out for our Mona Lisa laser touch. So for women who can't take estrogen because perhaps they've had a stage 2 uterine cancer or they've had breast cancer and they're not comfortable taking vaginal estrogen, we have the Mona Lisa laser, which is able to treat the symptoms of low estrogen in the vaginal area. It helps with vaginal dryness, painful sex. It can actually help maybe reduce some of the symptoms of lichen and also can help with some bladder urgency. So both Susanne and I do the Mona Lisa laser, and it's just such a great option for women. I just wish more women knew about it and could have this option so they can continue. Saw a patient the other day for her touch up after a year, and she said it changed her marriage. She suffered from breast cancer, wasn't able to take estrogen, and it's helped her be able to reconnect with her partner in a way that's really special to them. So again, if this might apply to you or a friend of yours, please tell them about the Mona Lisa laser. It's just life-changing for women, and we're glad that we get to offer it here in West Michigan. So I guess on that note, guys, anything else?
Well, happy Menopause Month.
Happy Menopause Month. And we'll see you on Wednesday, November 16th. Dr. Egan is going to talk about the sugar fix, what women need to know about blood sugar. So we look forward to seeing you then. And in the meantime, happy World Menopause Month.
Bye. Good night.
Not your mother's menopause.
Yeah.